everyone to 988 Suicide Crisis Lifeline Reflections on 2 years. We're so happy you could join us today, July 16th, on the second anniversary of 988 going live. People are coming in right now, so we're going to give it just a minute as they join us, and then we'll get started. Thank you for your patience. We've got 2 minutes after. We've got a good group who've joined us thus far, and I again want to say welcome. Please allow me to introduce myself. I'm Debbie Plotnick. I'm Executive Vice President for State and Federal Advocacy at our Mental Health America office. And today we're holding a webinar celebrating the second anniversary of 988 coming online July 16th. One of the wonderful programs that I have the privilege of helping to coordinate is our Regional Policy Council. And our Regional Policy Council pulls all of our MHA affiliates together across states, working with different clusters of states and finding out what's happening, sharing information, and helping everyone become better informed. One of the things that I'd like to do as we begin is to thank our 2024 sponsors of our Regional Policy Council. This year, they're Compass, Johnson & Johnson, Pfizer, Myriad Genetics, Neurocrine, Utska, Sage Biogen, Takeda Lundbeck, and Teva. We thank them for their support that allows us to have wonderful webinars like today. Our Regional Policy Council is so fortunate to have picked 4 of the most amazing policy leaders from our Mental Health America affiliate, and they're Barb Johnston of MHA in New Jersey, Ben Harrington of MHA of East Tennessee, Shauna Movahill of Mental Health Minnesota, and today we're going to be joined by Laura Evans from Vibrant Behavioral Health, where the 988 Lifeline is based. So I'm going to turn things over to Laura. Laura, take it away, please.
Thank you so much, Debbie. I'm Laura Evans, AVP of Public Policy and Government Affairs with Vibrant Emotional Health. And as Debbie shared, Vibrant is the administrator of the 988 Suicide and Crisis Lifeline. Before I introduce our panelists, I'd like to also thank Alicia and the entire MHA national staff for providing space here for this important webinar. And of course, all of the clusters and affiliates who participate in the Regional Policy Council. I'd like to thank our federal partners, the Substance Abuse and Mental Health Services Administration, SAMHSA, for their support in uplifting this important program. And then I want to thank everyone here and everyone within the MHA affiliate network. Your organizations have been vital advocates in the success of the creation of a national 3-digit number for mental health emergencies becoming a reality. And so I want to acknowledge that. And not only were you all a part of that success, but you guys are also critical on the ground stakeholders in ensuring that every community across the country is aware of the 988 Lifeline and that the crisis continuum shifts to be more responsive to those in need. So it's been my pleasure to work with so many of you on this initiative, as well as other initiatives throughout the RPC. Just to note for this webinar, our intention is for this space to be a space where MHA affiliates can not only hear from leaders on the federal and administrator side of the 988 Lifeline operations, but for you all to share your experiences, feedback, and questions with us. So with that, I'm very excited to introduce our esteemed panelists. First, we have Monica Johnson, MA LPC, who is the director of the 988 and Behavioral Health Crisis Coordinating Office. Ms. Johnson has worked in the behavioral health field for 26 years and most recently served as the interim commissioner for the Georgia Department of Behavioral Health and Developmental Disabilities. Prior to this role, she served as the division director for the Division of Behavioral Health for 8 years, the community mental health director for 3 years, and the child and adolescent mental health director for 1 year. And then following Monica, we'll hear from Dr. Tia Dole, who is the Chief 988 Suicide and Crisis Lifeline Officer at Vibrant Emotional Health. Dr. Dole is a licensed clinical psychologist and a longtime advocate for the rights of those with intersectional identities. Prior to stepping into this role of Chief 988 Officer, Dr. Dole was the Executive Director of the Steve Fund, the nation's only organization focused on the mental health and well-being for young people of color. Additionally, Dr. Dole was the Chief Clinical Operations Officer at the Trevor Project, the world's largest suicide prevention and crisis intervention organization for LGBTQ youth. And Dr. Dole oversaw all of the Trevor Project's crisis services programs, as well as their volunteer and community programs, and increased their impact by a factor of 4. So with those 2 great women leaders, I'm very excited to turn the floor over to Monica Johnson. Monica.
Thank you for that, Laura. I am simultaneously trying to share my screen. Do you see my screen? Perfect. Thank you. Thank you, Mental Health America, for this invitation. Today is our anniversary, so it feels celebratory. It feels like also, whew, we made it. We've done a lot in the last 2 years. And as I reflect on my own journey, 2 years ago, I was on the implementation side of this at the state level. So have had a very interesting perspective of spending at least 6 months in that space. And then I've been now with SAMHSA for 1.5 years. Time literally flies when you're having fun. So I'm so honored to be here with you. I want to start like I've been talking all day. I said this to the team earlier because we're celebrating today. We are celebrating where we are. We're celebrating what we've accomplished, but we are also very optimistic about what is ahead and how much more there is to be done. We are laying the foundation. And when I say we, I mean the collective we. So it is all the people here. It is the advocacy. It's the state policymakers. It's people. It's individuals seeking care and shaping this. It is the whole entire ecosystem that is necessary to make this really, really big group project happen. So I hope that today feels like a moment not only to be grounded in just the gratitude of how much we have done together, but also how much more work we have and that we will do that together. We are laying, again, the foundation, and we are all collectively a part of history. This is a historical moment. There will be decades to come where people will be talking about 988, what it is, how did it start, and you all will be a part of the fabric of that story. So be proud in this moment, be grateful, but continue to also push us so that we can leave behind a legacy for our children, our grandchildren, our great-great-grandchildren, where 988 is a nationally known, easy to remember number about a 3-year-old, right? That's my goal. So I'm going to spend a few minutes with you today talking about what we have accomplished and what's on top of mind for us. And then I will turn it over to my colleague, Dr. Dole at Vibrant. So what we do know is that in these 2 years, we are connecting more people to care than ever. Over the last 2 years, we have been able to answer 10 million chats, calls, texts, the whole modality. We've been able to hit that mark. That is remarkable. Nearly 6 million calls have been answered, nearly 1.7 million texts answered, and over 1.3 million chats have been answered. What we also have been doing is working to expand access, and we'll continue to do this to really make sure we're targeting at-risk populations and other specialty populations to make sure that we're being culturally competent and et cetera. So far, nearly 110,000 Spanish language access for calls, texts, chats have been answered. Over 475,000 LGBTQI+ youth and young adults contacts have been answered, and 20,000 video phone contact answered in American Sign Language. That one is really special to me, just from some previous work related to individuals that are deaf or hard of hearing, and for whom ASL is their preferred mode of communication. For us to be able to pull this off at the beginning parts of building out the foundational work is phenomenal, and just something I'm really, really proud of, that we've been able to do as a collective community. Nearly $1.5 billion in investments have been made from the Biden-Harris administration that have not only strengthened and expanded the 988 Lifeline capacity and services, but helped along the crisis care continuum in different ways across our agency. So I always say, when I get an opportunity to speak to anybody about 988, whether it's people I know, whether it's random people in the grocery store, because I am that person that randomly asks, have you heard of 988? I say to anyone that I'm talking to this about, that this is such a pivotal moment. 988 is a catalyst. And the reason, the evidence behind what I say, you don't have to just take my word for it, but we watch the legislation that is happening across the country as a result of 988. I have been working in this field for 27 years. I have spent my whole adult life in behavioral health care at all types of levels of positions. And I know for a fact, I feel very confident in saying this, that you don't see this type of activity unless there's a lawsuit. Like, states don't typically move this fast unless they are being required to. So while there is a law related to 988, we see a lot of different activity happening because of 988 being a catalyst. So you can't just talk about 988 in a vacuum without talking about how do you fund and support the crisis continuum. And you can't have that conversation without talking about preventive measures. And you can't have that conversation without also talking about what happens when the crisis is over. Crisis is a moment in time. So what does your whole continuum look like? So this type of transformation that we're seeing is phenomenal. We see that, at least in this moment in time, 10 states have instituted a 988 fee, 9 have created an advisory board, 14 have established a trust fund, 8 have strengthened crisis care insurance coverage, 7 studying 988 finance or gaps in the crisis system, and 30 have passed some type of an appropriation for at least one of the core 3 crisis service areas. So if that's related to the contact center, if that's related to the response mechanism, that may be mobile crisis. In some states, they may have legislation for co-responders, so it may look different. And then a safe place to receive help. That can look a lot of different ways: community crisis stabilization programs, peer support centers. It can look a lot of different ways, but we see a tremendous amount of activity happening as a result of the work. So I don't have the time or the slide space to really outline all of the goals that we are working on. We are a very ambitious team. We are working fast and hard to try to make things happen while we can, and take advantage of the moment that we have. I encourage all of us to continue with this level of energy and passion, because we don't get these moments, and history tells us often. So shame on us if we don't do all that we can to really be transformative in this moment. So some of our key goals, this is nowhere near an all-inclusive list. Top of mind for me is geo-routing. You may or may not know that most of the way the call routing system works now is based on area code. Everybody except for my mom doesn't have my mom is the only person I know that has a house phone. Most people have cell phones at this point. And so you can have an area code that is not reflective of where you are calling from. And so wanting to make sure that geo routing is implemented, because we really need to make sure that people are connected to local resources for a variety of reasons. But the biggest is that resources look different across this country, even within states. And so really being able to connect in a better way to get to those local resources is really important. And also, if there is a response that is needed to support an individual, being able to have better information about where the call is coming from is really important. Continued improvement of just our operational response period, including transparency of 988 outcomes. We have just finalized a evaluation plan that we are very excited about because it's people are wanting to know, well, okay, we did this thing. What are the outcomes of that? So really moving past keeping up with the metrics that we're monitoring, the key performance indicators, but really wanting to know more about what is this looking like in systems? How is this transforming the way policymakers are setting up their systems? And then also, what is the impact of all of this work on individuals that we serve and support? Standardization of documentation, data visualization. We want to be transparent about information that we do have, continuing that. Continue expansion of local chat and text. This is important, really important for us right now, a very high focus area, just because of the volume of text that people are now using more and more and more text. So making sure that we're building up that local capacity in partnership with states, improving the way we collect data, and then ongoing every day, raising awareness and building trust in 988. Just because someone may have heard of it doesn't mean that they trust it to use it. So really just quickly, this is just a real quick overview of what geo-routing looks like. We are hoping that in this next several months coming up within this calendar year, that we will be able to turn on some geo-routing. We have been working closely, obviously, with Vibrant, but also with our partners at the FCC and with the the 3 major carriers to make this be a reality. And we are very close. If you're not tracking this, but I have a feeling you all are, the FCC did issue a notice of proposed rulemaking to improve call routing. That was good news for us. We were already working in a voluntary way with the major carriers for this work, but that was a great move, and we were excited about that. So we'll continue to move forward with this work. We just recently launched our 988 National Paid Marketing Campaign. We are running research-informed advertising nationwide during 5 months, starting in the summer, fall of 2024. This actually started June 1st. And we're targeting and then also staggering who we are trying to focus in terms of our select audiences and how we're going to stagger the promotional marketing over the next several months. And so as you can see here, we are focused on LGBTQI in teens and young adults, American Indian, Alaska Native teens and young adults, and then Black teens has been our initial focus over the summer. We'll continue to move towards a much more robust, comprehensive campaign. We already work very closely with Vibrant to add more audiences as we move into the fall and winter parts of this year. So it is really hard, as you heard me try not to do earlier, is to only talk about 988 in a vacuum. And so a part of what we are also charged with is to make sure we're building out a robust system of care as it relates to behavioral health crisis systems. And so again, looking at the whole continuum, my experience, for those that don't know a lot about me, my experience comes from the behavioral health spectrum as a whole. So it's really hard for me to turn off thinking about all the preventive things that need to happen and still need to take place. And what does an outpatient full continuum really look like for children, for adults, for young emerging adults, and for older adult populations as well? It looks different across the continuum. Also, when I speak about behavioral health, I'm not just only speaking about mental health. I'm not only speaking about suicide prevention. I am thinking about substance misuse collectively along with behavioral health. So there's a lot that has to happen to really make this come into fruition. So some of the challenges that we have within our network that we know about and that we're constantly really looking for ways to improve, support, train, provide technical assistance, all the things. But the first one, no surprise, is workforce shortages. We saw that before implementation. We continue to see some of that. Geographic challenges. So when you think about like rural versus urban, when you're starting to build out things like mobile crisis and considering the travel time and the differences that those programs look like in a rural area, becomes an important factor. Thinking about telehealth and the limitations for those that don't have the appropriate equipment to even engage in those type of services. Financial resources, while we know this is always a challenge, but we do have some ways in which we're looking at how do you build pieces, like take pieces of this funding and this funding to blend and braid to really build out these systems. There is a 5% set aside for crisis care in the mental health block grant. There is Medicaid Institutions for Mental Diseases rule. Non-licensed staff and billing are challenges that come up often. We'll continue to work with our partners at CMS around the sustainability financing components, and some of that work is well underway now. Ongoing provider training needs, I think is pretty straightforward. And then the connecting again to crisis care, and you can see some examples there of what those challenges look like. So, like I said before, biggest group project ever. It really is an ecosystem. It's not just about the behavioral health system. It takes all entities, and you can see some examples here to really build out what we want to be able to see in the future. Really quickly, because I'm running out of time, just want to leave you with some resources. Here, there are two, and I believe you all will get these slides. There's two ways in which you can get information and promotional materials for 988. You can go to samhsa.gov /988. We have FAQs, we have performance metrics. There's the partner toolkit. So just a plethora of information that you can use to help get the word out about 988 and learn more about where we are. You also can go to 988lifeline.org for direct access to 988 Lifeline counselors and etc. I believe this QR code does actually work. And so if you want to sign up to get email updates from us, you are able to do that. And you can do that either with this QR code, or you can just go to the website that is here in the deck that I believe you will get. We do also have a 988 Training and Technical Assistance Center. We are doing everything we can to help communities, states, other partners really build out their work. And so we've done a series of webinars, we've done a policy academy, and there's so much more to come. And so if you're interested in receiving information and being on the listserv about our Technical Assistance Center, here's a QR code for that. Thank you so much for, again, allowing me the space to share with you all today on this very important anniversary day for us. And I think I turn it over to Tia. Dr. Dole?
Listen, I'm always going after you. And I don't enjoy it because you do such a wonderful job presenting. So, let me put my camera back on. One of the things I wanted to talk about, especially given that Monica was really talking about the achievement of the last 2 years, is really for folks here to understand our role at Vibrant and to understand how important the last few years have been. I do think, Monica, when you said this is the biggest group project, my thought was, nobody wants to work on a group project, right? Whenever my kids get assigned a group project at school, I get text complaints. And so what I think is different here is that everybody wants to help. And one of the things I see, and you know, I started working in the field of suicidology in the 90s, right, which tells you how old I am. There was no place to go, right? People would be suicidal; they'd end up in the ER, or you know, police would show up at their homes; they'd end up hospitalized. And the idea that we have 988 as the connector, we are one stop on the crisis continuum, but I tend to think of us as the stop that connects to people before they get in crisis, that connects to people while they're in crisis. We connect to family members who reach out to us, and then we also connect folks at the right level of care after reaching out to us. So we're connecting folks with mobile crisis team versus calling 911 or emergency services. And so one of the things I want to note is that 988 is not the thing that's going to end suicide. It's one of the things, and this is my goal in life, right, is to end suicide in this country. And so, you know, I think it's important for folks to understand how 988 works. I do have slides, but I'm not going to share them. And I'll say why is that Vibrant, we're the administrators of 988. We're in a cooperative agreement with SAMHSA. And as you could see from Monica, we are eternally grateful to have the best team on the planet working with us from SAMHSA. And we work with them, we talk to them every day, and we are in charge of different aspects of 988. And I think it's important for folks here to understand that we are in charge of telephony. We are in charge of providing something called the Unified Platform, which is basically a CRM for call centers to use for free. We are accountable for network performance. We're accountable for folks answering calls, making sure that everybody is served in a timely manner. We work closely with SAMHSA with comms and marketing. That campaign, which I don't know if you all saw, it was like a marketing campaign on something called Twitch, which is thing that young people do to stream. They watch other kids or other young people stream them playing video games, and we're advertising on there so that they can reach out to us. And all of our advertising campaigns, as an FYI, was based on formative research and collaboration with SBRC, which is really wonderful. We're focused on wellness for the network, for crisis centers, quality and training. We review thousands and thousands of transcripts to ensure that the calls are appropriate, to ensure that the individual contact is receiving the right level of care. And we're also, we work with folks along the crisis continuum to make sure that our crisis teams are our crisis centers are connecting with mobile crisis team, local 911 affiliates. And it's an interesting dynamic. Because one of the things that people are like, well, when do I call 911? When do I call 988? And you know, they are very different, but it's our hope that folks will call 988 in a mental health emergency so that we can help. And so it has been a collaborative relationship. And realistically speaking, these are our stakeholders, right? We have SAMHSA. I'm a person who just gesticulates while I'm talking. We have crisis centers, we have state entities, we have the crisis continuum, we have stakeholders like you all, right? And then we have the public, and of course, at the center of everything are our contacts, right? They're the individual who reaches out to us. And so one of the things I want to note is that we are listening to folks on both sides. And what we're trying to do, ensure that we are accessible, we as in Vibrant are accessible to you all. That's part of the reason why I kind of asked to be invited to this conversation. So in sum, what I'll say is that for me as an individual, I'm a clinical psychologist, and I came to this work through working with LGBTQ young people. I am in awe of where we are today. And someone literally asked me today, would you consider 988 a work in progress? And I said, ooh, And I thought about it for a moment because my first instinct was to be like, well, don't ask me that question. And I was like, actually, yes, it is. And it has to stay a work in progress. If 988 in the crisis continuum is not constantly iterating and making itself better, it's dead in the water, right? So my hope is that 988 will continue, and it may not always be at this pace because I can tell you it's a breakneck pace right now. But it it will continue to evolve. And I think that when I think about the folks in this call, and I saw a bunch of names that I knew, this is our legacy, to Monica's point, to our children. And this is transforming crisis services. I was recently abroad, and sometimes people say, "Oh, the United States isn't so great about different things." But I was abroad, and I was in a conference, talking to other people from different countries about what their crisis system looked like. And people were coming to me saying, "We want a 988. We want what you all have done in the United States." And I thought, my goodness, we've done something really special here. So I actually also wanted to express my gratitude to folks in this call, because I know some of you are instrumental on the day-to-day work of 988, instrumental in the policy work of 988, instrumental in carrying out the word of 988. So I just wanted to say thank you. And that's all I'm going to say today.
Thank you so much, Tia. Thank you so much, Monica. Well, our chat is lighting up with lots and lots of questions. So in no particular order, early on, somebody asked about 988 and folks with autism. Any specific information that you can share on that?
I can add a little bit there. So for me, when we talk about the evolution of the work ahead, it is I recognize that people present in crises, and it is often difficult in the moment sometimes to decipher the behavior versus the symptom, etc. And so we talked about, or I talked about, when I think about behavioral health, I'm thinking about mental health and substance misuse. But I also am constantly aware and thinking about behavioral health and its intersection with intellectual developmental disabilities. And so we do have a pretty good partnership with ACL, the to the assisted community living organization, to make sure that we're thinking about individuals with IDD as well. Because what I do know is that individuals can present in an emergency room and they are in crisis, and the system often does a disservice to individuals that present with dual crises, because people often don't know what to do. They're not sure what path. They're not, people within networks get to choose. They get to pick and choose which, we have bed availability for this person, but not for this person. Those are the realities that happen in the system. And so it behooves us to have these partnerships and to be thinking about those intersections, because they are real. And I could go on and on about that. So I'll just stay in that space. So the answer is yes. It is absolutely something that is being contemplated in how we provide training, how we provide technical assistance. Is the kind of tangible work there. But then there has to be the resources in the communities to be able to respond to, treat, and or support individuals that fall in the, what I would say, the IDD continuum.
Thank you, Monica. A lot of folks are asking about demographics. Tia, can you talk a little bit about like the largest age group that comes, or what folks are telling you? What kinds of things? We know this is free and anonymous, but folks do tell you things. So tell us a little bit about the demographics.
Well, so I'll say that our demographics are unreliable at best. And the reason for that is that unless the person is sharing information about themselves that is pertaining to the presenting issue, we're not saying, "And what's your ethnicity?" Um, and so it would be an inappropriate part of the conversation. And so where we find most of our demographics is via our pre-chat survey. So if you're on the chat, you can fill out information, and we have some post-chat information. So realistically speaking, having a truly accurate information about demographics beyond, let's say, generally age is something that, while I ideally would like it, is not really appropriate in the context of a call conversation. I will say, as a caveat, we do know that younger people use chat and text. No surprise there. Most of them don't even have voicemail set up. And then on the other end is that we do know that we have obviously folks who are calling the LGBTQ line who are outside of that demographic. Realistically speaking, it's supposed to go to age 24. But if I'm an LGBTQ older adult, I'll still press 3 because I know that I'm going to have a counselor who's trained in LGBTQ things. So I can say that we have trends, but we don't have anything that I would consider to be very accurate. Monica, I don't know if you wanted to add anything to that. Okay.
That's very helpful. Thank you. I think that really speaks to alleviating some concerns that we've heard out in the field about not knowing who folks are. And unless they tell you outright, you really don't know. And that's important. Another thing that's coming in, speaking of trends through our questions, are a lot of concerns about rural areas. This is something that we at Mental Health America look at a lot. I personally sit on the board of the Rural Mental Health Association, that it's hard when you're in a rural area where there aren't services. How's the crisis text and Lifeline taking a look at these issues in rural areas?
I can start with why the continuum is important. So I think what 988 does is create a space, right, for more people to reach out, to be connected, for either support, help, whatever, depending upon the needs of the existing crisis. But that's why I said you can't just talk about that in a vacuum, because there has to be and then what happens post the call, and what can happen prior to waiting until there is a crisis to reach out to a system for support. And so I think what I have seen and what is happening as I travel across the country, and I come from a state that is mostly rural. I'm from the state of Georgia. There is Atlanta, and then there is Georgia. And so there's a very, very big state, 159 counties. And if you see one county, you've seen one county. And so I do think that states and local municipalities, local areas and communities have to be thinking about how to make investments in their continuum of care, and be thinking about how do people then access those services. Thinking about, because it's not like urban communities don't have access challenges, because they do, it just looks different. But rural communities, if there's not the appropriate internet services available, there's not enough broadband, right, available, then you're talking about just some basic fundamental infrastructure investments that may not seem like they're related to behavioral health. But if you say we have telehealth services because we can reach more people, but if I don't have good internet connectivity or availability, because that's not available in my area, you have an access issue. So I'm thinking about that slide where I had the ecosystem. The ecosystem sometimes looks like not the traditional partners that you would think about. So I think it really requires taking a look at all of the things, all of the people whose voices need to be heard and whose expertise need to be brought forward to shape what is appropriate for the communities that exists within the states, territories, tribal nations, et cetera, because it looks very different. And that's why I love this program, and the partnership between the federal government and the state government is because we're not saying we're going to design all this for you. We're saying we're going to be a partner with you because you know your community, you know your citizens better than we do. And so there is that partnership and collaboration that needs to happen. So I say that, and I could speak on this topic also for a long time, but there's very specific needs for like your farming community. We know that we're probably not reaching that community in the way we want, but then I also know of local initiatives where they're doing some pretty creative things. And so I think there's a lot to still be learned, but those are some of the challenges I think that exist. And it really does take a true ecosystem to solve for some of those challenges.
Tia, did you want
And
to add?
I will say all yes. And in many rural places, 988 is the provider. And there are folks that call us every day, and we will continue to answer their calls. Mhm.
That is really important. So we also had some folks ask us about AI. Everybody's thinking about AI. Does this in any way fit in with 988? And if so, how?
Go ahead, Tia.
Okay. So I actually know a number of crisis centers are starting to explore AI in what I would consider to be incredibly exciting ways. I will say this is not the opinion of SAMHSA, uh, but my thought around AI is that the deployment of it, generally speaking, should be focused on helping the counselor. That it's never should be contact facing. And I think what some of the crisis centers are doing is using AI to help with their QI, right? So when you're reviewing thousands of contact transcripts, right, that's a very intense job. And the ability to do so quickly, to look at an individual crisis counselor and see how they do throughout their shift, which is by hour 5 of your shift, your empathy score starts to drop. You probably should take a break at this time. I think that AI could and will be an incredible resource for crisis counselor. Also, I think that the machine learning or the AI used for training, I think could be incredibly helpful, because training individuals to answer chat and text in particular is very time consuming. And so you can train essentially bots to mimic being help seekers. And and actually, there are several crisis centers across the country that have started exploring that. And they name the bots; they become their own persona over time. And so, from my perspective, I do think that AI will be incorporated in individual crisis centers across the country. How it would be incorporated in 988 remains to be seen. I think that that's a conversation that we are having. But I would say it's low and slow, primarily because it is a federal government. We want to make sure that anything that we do is not going to put anything at risk. But I do love the work that the crisis centers are doing. Monica, I don't know if you have a difference.
No, I actually agree. I mean, we're not looking at AI in any way for consumer facing or individual facing to take the place of a crisis counselor. But there is some work around what Tia talked about, the quality monitoring and work that I do think could have some benefits. And so we're not in any policy making space around this right now, but Tia, I think, did a very good job of articulating some early thoughts.
Right. In terms of following up with folks, what kind of follow-up is there for when someone calls into the crisis center? Is there follow-up that comes back? And how about for monitoring their satisfaction with their interaction with the 988 phone counselors or text counselors?
I'll start out by saying that every crisis center is accredited by ICH or AES. Both of those accreditations require a certain degree of follow-up. And so I can say very, very straightforward, 100% of crisis centers do follow up. Now, the level of follow-up that the crisis centers do is based on their own policies. All these crisis centers are independently operated, right? There's about 215 of them. I know 1 or 2 of them do 100% follow-up. But they have a very small volume, and doing follow-up actually takes away from direct service crisis counselor time. And so anybody who has said in a crisis conversation, I'm thinking about ending my life in the next so-and-so period of time, they will receive a follow-up. And so it really is about where they are escalated in the crisis. Are they at high risk? Are they, ultra high risk? However, the crisis centers, they are required to give a follow-up. And so I think that's helpful to know. And I hope that answers your question.
That was really helpful, Tia. Another area along the same lines that people are asking about is education for the counselors, and how uniform is it or isn't it?
So each crisis center, again, because they're accredited by ICH or AAS, have their own crisis counselor training. It hovers somewhat between 35 to 40 hours. And at the end of the training, they have like like a follow along, right? So they're on the lines and they're receiving really direct supervision and support while they're on the lines. After they graduate and become a counselor that's somewhat independent, the training that they provide, the crisis center is required to provide some type of ongoing training. However, this is where Vibrant tends to step in, which is that we offer both synchronous and asynchronous training that is generally topical. Our most recent trainings included updated risk assessment. It'll include special populations. People really enjoy our webinars that are related to working with, let's say, Black youths on the line. And so we try to make sure that that the trainings that we're pushing out are pertinent to current times, right? So my guess is that in the next month or so, we'll have a synchronous webinar about how to support people with election stress, things like that. So they're both topical. And then also most of our trainings are now available in Spanish. That way, some of our crisis councils are monolingual Spanish speakers in Puerto Rico. And so we're able to offer them a similar level of training in their native language.
Great, thank you. Folks are wondering about whether when people call, and if they call more than once, are they able to speak to the same counselor they spoke to before, or do they have to go through the story again with somebody else?
So that's a really great question. I can say that some contacts do counselor shopping. And so they'll call until they get the person that they want. And some of our contacts actually kind of figure out when the counselor works, and they'll make sure that they call at that time. But no, people are not guaranteed that. And I think the follow-up question to that question is, in terms of the contact record, does each person who reaches out to 988 have a profile? Within our system, the unified platform, they do not. And the reason for that is, there's a lot of ambivalence about an individual calling more than once. Having a profile where a counselor has put in their commentary about who they are and what they need. And so for now, we have kind of taken the position that each call is a standalone call. And it does benefit folks who are familiar voices, who take a lot more time, because when people see that the person called 10 times in the last week, it does impact how they interact with them. The crisis counselors are human beings. And if they have the sense that the person is sort of abusing their service, it actually impacts the level of care that that individual receives.
Thank you. Do you often send folks over to warm lines if you have someone who is looking for some more time and support in that way?
No. So we're not a fan of saying, we can't help you here. Let me pass you on to someone who can. We stay on the phone as long as people need to stay on the phone. We will give a warm line as a referral, but we don't pass people along if we feel like they're taking up too much time.
Right. Thank you. That's really important to know. I'm sure that really helps people feel very valued. And we love the fact that one of the resources are warm lines, as many of our MHA affiliates across the country run warm lines, and they do a terrific job. We have a question about how you might collaborate with public health organizations, locally, nationally, statewide.
So on the federal level, we're required to do that. The half of our office name is coordinating office. And so we have a charge of coordinating, so let me just back up. Crisis care and crisis continuum runs along like the whole behavioral health spectrum, right? So it's not you enter it at this point and exit or whatever. It runs across the continuum. I've used this for years. I think about the system as a bell curve. And so at the bottom of that bell curve, going from left to right, is like the crisis system. It is also where I see recovery. Like there are certain things that just are built out throughout the system and can be accessed at any point in time in throughout the continuum. So because of that, you can't build the work that we're doing in isolation. And so it requires coordination with other entities within SAMHSA. It requires coordination with other entities within the U.S. Department of Health and Human Services. So our partners like the CDC, Centers for Medicaid, Medicare, the Administration for Children and Families, Administration for Community Living. I brought them up earlier. We have a HRSA. So we have to use all of government. And then outside of the HHS services, one of our most primary partnerships is with the Veterans Administration. And so we have to do that in order to make this work. And then just knowing what I know of how states also operate, the same thing has to be true at a state level. You're ultimately building out systems of care, and you cannot do that in isolation. You cannot just put on blinders and say, I'm just worried about the crisis part of the system, because that system will crumble if that is the way it is built. So you need all of your partners, and you also need private-public partnerships. So when you think about this long-term sustainability of this, you're going to not just be able to rely on the public safety net system, but private partnerships and private payers also have to be an equal part of this work to make it work in the long term.
I want to switch gears a little bit and talk about advocacy, because advocacy is what got 988 off the ground. It's what's getting it funded in states. People have asked us what activities. We can say, as one of the national organizations, we collaborate with other national organizations. We collaborate with NAMI and many other national groups on helping get funding for 988 and those kinds of things. But what's happening on the ground in terms that you're hearing about building out that continuum of care that you mentioned, Monica, that Tia, we know is so important, about what's there and what advocacy is happening or should be happening or could be happening that you'd like to recommend, because some people are telling us that services in their area are very disjointed. So when folks call, it's very hard to get connected to a number of things in their area, and also about like how are the directories and things kept up to date in that, and how do we all work together to make that smoother?
So I could start with just some fundamentals. So we provide 988 capacity grants to the states, territories, and some tribal nations, communities. And within those grants, it's about building out your 988 capacity, but it requires partnerships. And so most states, maybe except for 3, do currently have that grant. And so it is an opportunity that should be there. And at the local level, as I'm thinking about local chapters, you should have voices at the table. I came out of state government. I was in state government for 12 years. You can't do anything without advocates. And so I think that having advocates at the table as a part of planning, as a part of the strategic thinking, is important. And if you don't have that and you're not at those tables, then I haven't met an advocate yet that has had a problem finding their way to that table. And so advocates are usually very, very good at positioning themselves to be at the right place, but seriously making sure that at these local levels, that just having the seat at the table and that you are holding kind of your systems accountable, I think is important. And I think that should just be the case in all things. That's what I'll say in that space.
It's wonderful. Tia, do you have anything to add there?
So, it's an interesting, the question of what each state is doing is interesting. I'm going to use that word interesting, which is open to interpretation. But what we can do, because we're just in charge of 988, what we encourage our crisis centers to do is to formalize their relationships with the mobile crisis team, with 911, and actually create MOUs, which are not about money, right? But it's about way of working to help facilitate the connection of the help seeker to the next stage of being helped. I'll say also, my guess is that geo-routing is going to be incredibly helpful for this, because right now I'm going to use, I saw someone posted about Chicago. Chicago's nice, right, is what they said in their thing. If you have a bunch of people in Chicago with their area codes that are going back to Georgia, that is actually also contributing to it not being particularly helpful. And so when they call, they're going to a Georgia crisis center. But once geo-routing is launched, then they'll go to their local crisis center. And then I saw another chat, I do read the chat, about resources. That individual crisis center does have resources. The best person to offer resources to an individual in Hyde Park in Chicago is the crisis counselor lives down the street. And so each crisis center does maintain resources that they're able to refer. So the geo-routing, I think, low key, will be incredibly helpful with this coordination.
Great, thank you. I'm going to invite Laura back to tell us a little bit more about what's happening at Vibrant. Thanks, Laura.
Yeah, thank you, Debbie. I am so pleased because I get to work with Dr. Dole every day. And of course, we work with our partners at SAMHSA, and Monica's team has just been so amazing. We're so fortunate. And of course, you all in the advocacy community, in the MHA network, are just really important. So I did want to make sure that I just highlighted a couple of things that have come up already. Monica mentioned the 988lifeline.org website, and I highly encourage that as a resource for folks to see the latest data and other information, FAQs around the service, particularly as you all are having conversations in your communities. That's going to be a wonderful resource for you. I also saw a question around workforce, and I'm going to put into the chat a link to a joint Vibrant SAMHSA NASHBID, the National Association of State Mental Health Program Directors report on crisis services workforce and recommendations, particularly for policymakers, including letting people practice or at least not having a license as a requirement for the line, because we know many people face barriers in getting licenses. I also want to make sure that I'm elevating the public policy web pages within Vibrant and highlighting MHA and the RPC as great resources. When it was geo-routing comment period for FCC, MHA shared a template that affiliates and really anyone could use to help weigh in. So I want to make sure that we are aware of these resources. And of course, if you have any questions, the MHA team or Vibrant, myself and others are available for you. So wanted to make sure I highlighted that, and I'll turn it back over to you, Debbie.
Thank you. Thank you. And I want to thank everybody who joined us today. Special thanks to our team behind the scenes, to Alicia and Jackie, and to our speakers, to our panelists, to Monica and Tia, and of course, Laura, who I get to work with on our Regional Policy Council. We have other events coming up. We will, the Regional Policy Council will be having an in-person meeting that will be at the same place and same time as National Conference of State Legislatures. We will be on in August in Louisville, Kentucky. And once again, I'd like to thank the sponsors of the Regional Policy Council: Compass, Johnson & Johnson, Pfizer, Myriad, Neurocrine, Otsuka, Sage Biogen, Takeda Lundbeck, and Teva. Thank you again for joining us. We look forward to seeing you on more MHA and more Regional Policy Council webinars. Thank you all. Bye.